Are you facing challenges in your health? Then Dr. Suleiman Clinic and Labs is here to provide you with the lasting solutions to your health problems. Dr. Suleiman Clinic and Labs is specialized and offers consulting in psychiatry, internal medicine, cardiology, urology, dermatology, gynecology, infectious diseases, and infertility. At Dr. Suleiman Clinic and Labs, we offer 3D/4D scan at just 5,000 francs, emergency ambulance, free ultrasound scan, and free medical consultations. Our staff is composed of well-trained doctors with good laboratory and best equipment. We are located in 2 cities, Boya at Mile 18 Bolifamba, and in Douala, we are located at Entre Pilot. You can reach us through the telephone number 694-940-172. Your health is at the right place with Dr. Suleiman.
Let's now talk about another very important issue, which is the rhesus factor. You know, blood groups, you hear, oh, I am A positive, I'm A negative, I'm B positive, I'm B negative. What does the positive mean? You just, the Rh factor, which is small antigen attached to the red blood cell, if you have that antigen, we'll call you positive. If you do not have that antigen, we'll call you negative. That's simply what it is. So what is the importance of that? Let me assure you, as a mother out there, if you are Rh positive, meaning you are A positive, the word positive is attached to your blood group, you have nothing to worry about. Again, if you are any blood group positive, A, B, AB, O, any blood group, and you see the word positive attached to your blood type, there is nothing to worry about as far as hemolysis of the baby or hemolytic anemia of the baby because of incompatibility. There is nothing for you to worry about. The baby is safe, you're safe, there is nothing for you to worry about. If you are negative, meaning O negative, A negative, B negative, AB negative, whatever blood group, and you see the word negative attached to your blood type, then there is something to worry about, but not really to worry about much because it's very easily handled. How? During pregnancy, if the baby have any anemia, again, when would you worry about that baby's anemia? When you are Rh negative, meaning the blood group, the blood type, and then the word negative attached to your blood type. And the husband is positive, of course. Because if you're both negative, there is nothing to worry about. No antigen will be formed. No antibodies will be formed. So if the mother is negative, forget about the father, we don't ask about the father. The mother is negative, we have a problem. Years ago, it was really severe problem, but now we do not have this problem because we have the technology and we find out what is the solution. So if you suspect that the baby has anemia, maybe she is in a village, she has no access to medical care, and suddenly she shows up in front of you, and you find out that she is negative and she has not been followed up. So what you want to do? You want to make sure that that baby, you do the ultrasound, of course, and you have doubts. The baby's heart rate is too high, that is possible anemia. So now there is invasive things we do, which I do not like to do, and there is very non-invasive. Non-invasive meaning not danger at all. You're going to put the probe of the ultrasound and find out if the baby really has an anemia or it doesn't have. We have in the brain an artery called middle cerebral artery, MCA, middle cerebral artery. We have the technology, we have the machine, even I have it in my office. It's a late ultrasound machine that can pick up the middle cerebral artery, and we see the peak, you know, the pulsation. The pulsation has a peak. So, you know, let's say we're looking at this height of the pulsation. If it goes to this high, that means high velocity there, you know, the peak is too high, then we know this child, this baby inside has anemia, hemolytic anemia, okay? So we don't have to go with a needle and take fetal blood and analyze and count. No, we don't have to do that because this is a procedure that is safely done these days, but why would you take the risk if you can do it without any invasion or any puncture or any of those things? We can simply find out if the baby has anemia or not by simple ultrasound. by simple ultrasound that has the, the capacity to do so. Not all ultrasounds has it, but most of the ultrasounds today have it. You can measure the velocity of the MCA. Velocity meaning the speed of the blood that runs inside that brain and that specific artery, middle cerebral artery. We see the speed of that blood. If the speed is high, that baby has hemolysis, has hemolytic anemia, and then you should be taken, you know, the doctor will be advising you what to do next, okay? So this is a very non-invasive procedure that we measure whether the baby have hemolytic anemia or not. You, as a mother, at week 28 will give you an injection, a dose of Rogam. At delivery, will give you another dose. End of story. But I said this just in case you out there nowhere where you have no access to medical care and suddenly you showed up, you wanna check the baby, you wanna check your pregnancy. At this moment, then it's very advisable to do the MCA velocity peak and see if the baby really has hemolysis. Or hemolysis means anemia because the red blood cells are being burst, boom, 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 being burst because of the incompatibility with the mother. So the antibodies from the mother fight the cells of the baby. Anyhow, I said it's very easy and it's very non-invasive procedure to see if the baby has hemolysis or not. We just measure the velocity of the middle cerebral artery in the brain while the mother lying down on her back. We can find that in 2 minutes. It's not a problem. Now we're gonna go to another very important issue that you as a pregnant mommy out there should be looking for, which is diabetes. Diabetes. Diabetes, some mothers do not have diabetes. Before pregnancy, she was never diabetic. She get pregnant, she developed diabetes. And guess what? 10 years after delivery, she will become diabetic. So, you know, pregnancy shows who is going to be diabetic later on. If you get diabetes while you're pregnant, most likely you will be diabetic after 10 years after delivery or so, okay? So why diabetes is very important for me to check when you're pregnant? Because of its complication. What is the most big complication for a mother to have diabetes during pregnancy? Macrosomia, big babies that is more than 4,000 grams, 4 kilos. Babies that are more than 4 kilos, that is the complication of a mother having diabetes during pregnancy. Okay, so what is the problem? Well, the problem is if this mother goes through vaginal delivery and she didn't have the proper follow-up during pregnancy, the shoulder of the baby can get stuck under the pubis of that woman. There are maneuvers that the professional will do to release the shoulder. It's very, you know, you need experience and you need to know how to do it. In this case, you can never use a vacuum or take out the baby by force. Why? Because that shoulder here is stuck under the pubis of the woman and you pulling out the baby, you're gonna have shoulder dystonia. Dystocia, the shoulder will not be coming out easy, and you're gonna hear the bone cracking. And you're gonna damage the plexus that's under here, the brachial plexus of that baby, and that baby may end up not being able to move his hand for the rest of his life. So that can easily be prevented if you know how to manage gestational diabetes for a mother. How is that? First, we're gonna recognize that this mother have diabetes. Well, we have what is called fasting blood sugar. Fasting meaning you didn't eat anything all night. You come in the morning to the clinic or to the hospital, and then we take your blood sugar level. It has to be at certain value. Then, not only that, then I'm gonna give you 50 grams of glucose. You eat, you drink, you wait 1 hour, then I measure your blood sugar and I write the value. After 2 hours, I give you 100 grams of sugar, glucose, and I wait 2 hours and I measure the sugar and I write the value. After 3 hours, I give you another 100 grams of sugar, I wait 3 hours, I measure the sugar and I write the value. Now, how many tests did I do? 4. Any 2 values that are abnormal out of the 4, you have gestational diabetes. Any 2 values out of the 4 that I made shows abnormal value, you already have gestational diabetes. So what is the problem? There's no problem. I'm going to confirm one more time, and I'm going to give you a sugar machine that you go test. You take breakfast, you wait 1 hour, you measure. You wait 2 hours, you measure. You wait 3 hours, you measure. And you write those values. You bring them back to me. We establish the values are abnormal. We establish you have gestational diabetes. What is the next step? You're going to go home and you're going to limit your simple starch, simple carbohydrates, you limit. What is simple carbohydrates? White rice, bread, anything that is made out of white flour, you avoid. That is simple carbs, simple carbohydrates. What is your advice? Take carbohydrates, but complex carbohydrates. Where can I find complex carbohydrates? In grains. Instead of the white flour, take whole wheat, beans, vegetables, plantains, yams, Irish potatoes. Those are all complex carbohydrates. Those are recommended for you to eat. Sugar, avoid. Bread, avoid. White rice, avoid. And then you will overcome your gestational diabetes. The baby will be delivered at normal weight and everything will be okay. We discussed gestational diabetes and we already told you what you should do about gestational diabetes. The most important thing is to know that you have gestational diabetes. Okay, and it's very easily done and very easily managed. There is no problem. So what if you do the diet for 2 weeks and you come back and you still have high sugar? What is the next step? The next step in this case, and it might sound harsh, but actually is the good treatment, insulin. Huh? You're gonna put me on insulin? I'm only 22 years old? You're gonna go on insulin because I cannot put you on tablets. Like any those oral hypoglycemics, forget about the term. Tablets to lower the sugar is not for pregnant women. We treat with insulin, injectable insulin. Why? Why you treat with injectable insulin? You know, because insulin is a big molecule that will not have the capacity to cross the placenta. So if you're pregnant and you go to a health center and you find your sugar is high and they give you a tablet, tell them no. Why no? Because some of those tablets will cause hypoglycemia to the baby and the baby will die of hypoglycemia. So if you have gestational diabetes, do not accept the tablets. The only treatment that is correct for you will be injectable insulin, because insulin is a big molecule and will not cross the placenta to the baby, causing hypoglycemia, meaning low sugar level. So we finished with gestational diabetes, and you already now, by this moment, you should know what to do when you have high sugar and how you discover yourself if you have high sugar, and what is the treatment for high sugar, and what you should do and what you should not do, and what you should eat and what you should not eat. Let's move to something else. You go to the clinic and the midwife tells you, listen, you are 28 weeks. But when I put my hand on your belly, it feels like you're only 20 weeks or 23 weeks, meaning you are small for dates. The dates show higher age of pregnancy, but by examining you, we show by putting my hand on the uterus and measuring, is it above the umbilicus, below the umbilicus, how high is the fundus of the uterus? We see that you're small for date. The actuality shows that your uterus is small. I have few minutes, so let me summarize this and we'll repeat again one more time. So that means that uterus with its content, what is the content of the uterus? The baby and the placenta and some fluids we call amniotic fluids. So that means the baby is grossly retarded, meaning the growth of the baby is not going. The baby is small. It's supposed to be at this size, but it's now at this size, small. What is the second possibility? That fluids inside the uterus, the amniotic fluid, is a small quantity. We call oligohydramnios. we have to understand something. Where is this amniotic fluid coming from? The amniotic fluid is coming from the baby's urine. When the baby urinate, that is the amniotic fluid. So the baby keep urinating. Where does this urine go? Oh, the baby swallows the urine. So, and then urinate. Then it swallows the urine. Then urinate. Then it swallows the urine. So this is recycling. Urinate, swallows the urine, and continues. And based on this mechanism, we have a specific quantity of amniotic fluid that we know. We call it amniotic fluid index, and it has to be around 25 or so. Anyway, we're not going to go into details. We just need to tell you, if the uterus is small birthdates, then we have to think either the baby is small, the pregnancy, the baby growth is retarded, is restricted, and we're going to explain what happened, or we will explain today the amniotic fluid that surrounds that baby is becoming less. And we said the amniotic fluid is nothing but the baby's urine. The baby swallows the urine, then urinate again and swallows the urine, and the mechanism continue, and that is how you have a specific quantity of amniotic fluid. What if the baby's kidneys are not working? If the baby's kidneys are not working, and we know the kidney is the source of the urine, then the baby will not be able to make urine, then the amniotic fluid will be less. And this is what we call oligo, mean less, small amniotic fluid, or small amount of amniotic fluid. So that gives me an idea. When I have oligohydramnios, I have to think that this baby's kidneys is defected, renal agenesis. Something is wrong with that baby's kidneys. What could be the reason? The mother most likely is hypertensive and taking antihypertensive medication that is called ACE inhibitors. ACE inhibitors is a category of antihypertensive drugs that can cause or lead to bad kidney in a small baby. So how do I know I'm taking ACE inhibitor? The doctor should know if you're pregnant, should not give you any ACE inhibitors. Anyway, if you look at your medication box, it will say at the end of the word Brill, P-R-I-L-L, Brill, anything, Ramipril, Captopril, anything that ends with Brill, that's an ACE inhibitor. And that's a danger to take if you're pregnant. You cannot take ACE inhibitors if you're pregnant because it will damage the baby's kidneys, and as a result, the baby will not be able to put out urine, and as a result, the amniotic fluid will be less. What if the baby cannot swallow? The kidney is okay, is putting out enough urine, but he cannot swallow that urine. What is the problem? We have a problem then up here in the GI system, in the gastrointestinal system. What if the esophagus is blocked? I mean, the urine goes through the mouth, and when it comes down, it finds a blind way, dead end. Okay, then he will not be able to swallow. Then in this case, what's going to happen? Well, the urine is putting out, but is not being sucked in by swallowing, so it becomes big amniotic fluid. This is polyhydramnios. In this case, we know the baby is defected, the GI is defected, and we have a small problem with the GI, with the esophagus, or a fistula between the trachea and the esophagus. We're going to touch up again on this one till you all understand what is going on. And thank you, and have a blessed evening.